Welcome to our webinar titled ASH 2022 Update on Aplastic Anemia and PNH. Thank you for joining us. My name is Lee Clark, Director of Patient Services, and I'll be moderating the presentation today. As we get started, I'd like to recognize the generosity of our corporate sponsors and the generous support of our patients, families, and caregivers for supporting the program today. Before the webinar starts, I'd like to let you know about a few other educational programs that we have here at the Foundation that may be of interest to you. This year, we are sponsoring several patient and family hybrid conferences in the US, and the conferences are located, our next conference is actually located in Salt Lake City, Utah, which will be on Saturday, July the 15th. This conference has special programming for our pediatric community. There'll be special programs for the pediatric parents. We'll also be having a kids-only program. Registration is now open on our website for our Salt Lake City program. I'd like to also let you know we have an upcoming support group this week, and this support group is our transplant for MDS patients. However, we have other virtual support group opportunities which are listed on our website, and all of our groups are listed on our website. So please feel free to take a look at those and join any of our groups that are of interest to you. Once you register, you will receive an email confirmation, and in that confirmation is the information on how to join the virtual group of your choice. Next week, we do have an upcoming webinar which will be hosted by Dr. Gail Robos. Dr. Robos will be talking about the new IPSSM for MDS, and that also is currently open for registration on our website. We do have two of our March for Marrow, which are our walks to help bring awareness for bone marrow failure disease. And we have our March for Marrow, which is in New Jersey, coming up in September, and our March for Marrow in Virginia, which will be in October. And registration will be open for those shortly. So it is possible that you could potentially lose your connection during the webinar. We'd like you to know that if you're unable to get back online, you can hear the audio portion of the program using the call-in number in your reminder email. Today's program will be archived to our website within 2 to 3 business days. You'll be notified by email when the program is ready for your on-demand view. Immediately following the presentation, there will be a question and answer session. Please feel free to submit your questions at any time during the presentation. To submit a question or comment, open the Q&A window in the lower part of your screen. Type in your question or comment in the small text box window. When you finish typing your question, just hit enter, and we'll do our best to get to everyone's questions today. When asking questions, I do ask that you do 2 things to help me manage the incoming questions. First, submit your entire question all at the same time. Second, please do not share private health information in your question. Our expert today cannot answer any specific questions related to your personal health care. Our specialist today is Emma Groarke. Dr. Groarke is a hematologist in Bethesda, Maryland at the National Lung, Heart and Blood Institute at the National Institutes of Health. She received her medical degree from the University College of Dublin. Dr. Groarke's research involves clinical trials in acquired and inherited bone marrow failure diseases. It's my extreme pleasure to welcome Dr. Groarke today. Thank you so much for joining us.
Thank you. Now let me just share my screen. Hopefully this will work. All right. So just to start, a photo from our AAMDS conference last year. And as Lee mentioned, my name is Emma Groarke. So I'm a hematologist at NIH, and I work primarily in bone marrow failure and primarily in clinical trials for bone marrow failure. And today I'll be talking to you about the highlights of the ASH 2020 meeting in regards to aplastic anemia and PNH acquired. And before I do that, I just want to give a brief overview of where we are at currently with therapy and some of the underlying pathophysiology of aplastic anemia, just to make it a bit clearer when I'm going through some of the abstracts, how these might change management. So to begin, aplastic anemia is a bone marrow failure disorder. It's characterized by cytopenias, and by that we mean low blood counts. So that's low hemoglobin, low white cell, and low platelet counts. Patients also have a hypocellular marrow. So that means that the amount of cells being produced in the marrow is low, and that results in this empty marrow that you can see here on the slide. And also what you see is hypoproliferation of blood cells. So we know that the bone marrow is not able to produce blood cells. And this is reflected again in the low cellularity marrow, but also on the blood count, where we can see something called the reticulocyte count, which is the baby red cells, is low. There are various causes of aplastic anemia. The commonest is acquired or immune aplastic anemia. And this is caused primarily by cytotoxic T lymphocytes, which destroy bone marrow stem cells. And this is the natural history of aplastic anemia. So this is what happens if you don't treat it. And this is a very old slide from back in the 70s. And you can see that without treatment, the majority of patients with aplastic anemia will die, unfortunately, of primarily infection and also bleeding. However, luckily nowadays, we have much better therapies and we have good options for most patients. And really broadly, this is broken down into two main treatment modalities, these being immunosuppressive therapy, which is now in the US, horse ATG, cyclosporin, and L-trombopag. And the other modality that's commonly used is something called a bone marrow transplant. And that's where the bone marrow from a donor is transplanted into the patient with aplastic anemia in order to repopulate cells. And the treatment approach really depends on two main factors nowadays. So one would be the patient's age. So particularly in children, we tend to go for transplant upfront, particularly if there is a sibling donor that's a full match. And in many cases also if there's a fully matched unrelated donor. In adults, we tend to look a bit more closely at the age because we know in older adults that transplant is riskier. So in adults over 40, we tend to go for the immunosuppressive therapy first, and this is the horse ATG, cyclosporin, and L-trombopag. In younger adults less than 40, we will still consider an upfront transplant if there is a fully matched sibling donor available. And there have been a lot of attempts to improve upon immunosuppression over the years. So horse ATG and cyclosporin was the standard of care for a very long time. And there were various attempts to either change the ATG into another agent that was stronger to see if that would help increase responses, or to add other agents to this to try and increase responses. And ultimately, the only thing that has really changed in terms of standard of care in aplastic anemia in the past 20 to 30 years is the addition of L-trombopag to the horse ATG cyclosporin combination. So this is now the standard immunosuppressive therapy that is administered. And that's based on a trial, which I'm not going to go through in huge detail, that showed higher response rates in patients who had the L-trombopag added compared to patients who had not had it added. And just for reference, this is the current standard regimen that is used in the US. So this is horse ATG, which is administered in hospital for typically 4 days. Patients typically go on cyclosporin high dose for 6 months, then lower dose for a further 18 months, and L-trombopag for 6 months. And just to mention that this trial was recently published and was performed in Europe. And this, again, was looking at horse HG cyclosporin eltrombopag and confirmed the findings of the NIH study, establishing this as standard of care in Europe as well. So this is the first abstract I'm going to discuss from ASH. And one of the questions that we've often had is, how long should the eltrombopag treatment go for? So in the initial NIH study and in the European study, patients received eltrombopag the majority of time for 6 months and in some cases for 3 months. But we don't really know what the optimal duration of eltrombopag is. So this abstract was looking at, if we keep the eltrombopag going for a longer period of time, will that improve things for some patients? And just to mention, I'm going to show the abstracts as they were presented at ASH. So I've gotten the slides and permission from a lot of the investigators. And I'll try to slowly go through and point out what I think is important on these slides. So this study included patients, so this was both adults and children, so age 8/2, and included patients with severe aplastic anemia and very severe aplastic anemia. So severe aplastic anemia means that your blood counts are pretty low. So it means the hemoglobin is usually less than 8, and reticulocyte count, which are the baby red cells, are less than 60. The neutrophil count's less than 0.5, and the platelets are less than 20. And most patients will be transfusion dependent. Very severe aplastic anemia just means that the neutrophil count is a bit lower, so at 0.2 instead of 0.5. We know that patients with very severe aplastic anemia tend to do more poorly and be at higher risk of infection than patients who have higher neutrophil counts. And in this study, patients received rabbit ATG and cyclosporin. And just to say that there are different formulations of ATG. Horse ATG is the formulation that has shown the best responses in clinical studies, but rabbit and porcine ATG are also used, and a lot of that has to do with availability around the world. So in this study, this was, I think, performed in China, and this was what they had available, which was rabbit ATG. And eltrombopag was used at this dosing. Again, this was a study performed in Asia where dosing is slightly different for eltrombopag. So this is full dose eltrombopag. And what you can see here is, so this is 6 months, and this is the amount of patients that responded by percentage. And over 70% of patients had a response overall. 20% of patients had what we call a complete response, which means that your blood counts pretty much normalize. And partial response means that your blood counts get better, but they're not quite in the normal range. And 6 months is usually when we make an assessment to say whether a patient has responded to therapy or not. And they looked at 12 months and they found higher response rates of 80%. And this was in many of the patients who continued the eltrombopag a bit longer. So I'll show you a breakdown of that now. So in total, they looked at 100 patients. Some ended up being excluded because they didn't receive the full course of eltrombopag. So they ended up with 92 patients. And of these, they looked at patients who at 6 months were called non-responders. So that means their blood counts hadn't improved at all, really. Complete responders, meaning that their blood counts were pretty much normal. And partial responders, which, as I said, the blood counts were better, but not quite in the normal range. And in someone who's a complete responder, there wasn't really any reason to continue the eltrombopag because their counts were so good. So these weren't really included any further in this study. And then they looked at non-responders and they continued eltrombopag in 11 of these patients. And of those, around half of them developed a response. So 1 developed a complete response, 4 developed a partial response, and 6 of them continued to not respond. And in patients who had a partial response, they continued eltrombopag in most patients. And you can see in these patients, the majority of patients did develop, or about half of patients did develop a better response. So they went into the complete response range. And that, I guess, went in and showed that patients had a better event-free survival. So event-free survival is a measure where, so an event we call relapsing needing a transplant or dying of your disease. So less patients had one of those outcomes if they continued L-Trombopag longer rather than discontinuing at 6 months if they were a partial or non-responder. Again, complete responders were not included here because they already had a good response. So I think this was an interesting study and does show that there are patients who probably will benefit from staying on L-Trombopag a little bit longer, particularly if the blood counts are not at an optimal range at 6 months. So I think this is something we'll need to look at a bit further. So the next topic I'm going to cover is what are the role of other TPO agonists. So L-Trombopag is a TPO agonist. So basically a TPO agonist TPO is a hormone that stimulates megakaryocytes. So these are the precursor cells that produce platelets. And L-Trombopag was actually first used as a drug for a disease called ITP, which is immune destruction of platelets. But in aplastic anemia, it's also been seen that it doesn't just stimulate platelets, it also stimulates hemoglobin and white cells. L-Trombopag was one of the first TPO agonists that was developed, but there are other ones that people are studying to see if there's any better efficacy or also if there's a difference in side effect profile. So one of the ones that's been more recently developed for the ITP setting is something called avatrombopag. So it works pretty similar to L-Trombopag. One of the key differences in terms of side effects is it doesn't have any liver toxicity. So I don't know if many of you are taking L-Trombopag. You may have noticed that we keep a very close eye on the liver test because we know that L-Trombopag can raise the liver testing to bad levels and sometimes we need to hold it. And one of the other issues that we see with L-Trombopag that's troublesome to patients is that there's a lot of dietary restrictions in terms of taking L-Trombopag. So you can't eat around the time you're taking L-Trombopag and you can't take calcium, mineral type products around the time of L-Trombopag. So avatrombopag doesn't have those types of restrictions. So this was a pilot study where this avatrombopag was used in substitution for L-Trombopag. There are only 32 patients, so it's not a very large study. And again, it was porcine and rabbit ATG used in combination with cyclosporin and avatrombopag. And these are the 6-month response rates. So this is the total number, including the very severe and severe cohort, which is 62.5%. So it's hard to tell given that these are low numbers, but it does seem to be efficacious in aplastic anemia. Maybe not as good as some of the numbers we've had on the L-Trombopag trial, but again, hard to know because numbers are not really large enough to make this determination. So I think all we can say from this is that it seems to work potentially and probably needs to be studied in a larger study. One thing to mention here is that there weren't any patients who had to discontinue the drug due to adverse events. So that's another important thing to mention. And this is another study. So this is a different study, which we don't actually have any results on yet, but this was presented at ASH as a trial in progress. So this is the Diamond Ava first study, which is currently, I believe, undergoing enrollment, but they may have finished accrual at this point. It's a phase 2 clinical trial. Patients will receive horse AGG cyclosporin and avatrombopag, and it's very similar in design to the 2 studies I showed you at the beginning of this talk, the NIH study and the European study. And they'll look at outcomes at 6 months, 12 months, 18 months, 24 months. In terms of response, relapse, overall survival, and clonal evolution. So I'll be interested to see if avatrombopag performs comparatively to L-Trombopag, because it would be a good option in patients who may have problems with liver toxicity or if there's issues with the dietary restrictions. So next, moving on, so that I'm talking there mainly about upfront therapy for aplastic anemia. Now moving on to relapsed and refractory. So this is a patient who might have received immunosuppressive therapy, but has not responded. What do we do? So there's 2 main things we think of. One is giving immunosuppressive therapy again, and the second is transplant. So I'm going to talk now a bit about transplant. So this was the main transplant abstract that was presented at ASH. This was looking at alternate donor bone marrow transplant for severe aplastic anemia. And just a bit of background about transplant and aplastic anemia. So the kind of things in favor of transplant are it's really the only curative option for severe aplastic anemia patients. So we know that patients treated with immunosuppression have similar overall survival to patients treated with transplant, but there are risks of relapse long term. So there is a chance that blood counts will drop again and patients may end up on medications long term. And the other thing to consider is this long-term risk of clonal evolution. So we know that patients with aplastic anemia have an inherent risk of developing myelodysplastic syndrome, which is a type of blood cancer, and also PNH, which I will discuss in this talk later on. So that does get eliminated by transplant. The issues with transplant always in aplastic anemia have been risk of graft failure. So this means that when the stem cells are infused into patients, that the cells may not take up properly, and also graft versus host disease. So graft versus host disease is when the donor graft considers the host as a foreign invader and can attack it and cause organ damage. And this is a long-term complication of transplant that is quite significant in some cases. And also to mention that particularly in older patients, just the process of transplant itself can have a higher mortality just because there's chemo given, there's a period of prolonged immunosuppression where the blood counts are very low and there's risk of infection or other toxicity from the chemo. So these are all things we need to consider when we think about transplant. And this is use of haploidentical transplant. So in transplant, we have what we call fully matched donors. So they're 100% match, and then haploidentical is typically a half match donor. And in the past, this was of concern because the less you're matched to your donor, the more the risk of those two issues. So the graft failure, so the graft not taking up properly, but also just risk of graft versus host disease. But there's been a lot of work done recently in the field of transplant to make haploidentical transplants safer. And this is mainly in regards to the types of chemotherapy that are given. So this is a study that was performed at Hopkins. And actually, I think the full results were just published and were also quite promising looking in a medical journal. And this is actually looking at upfront therapy. So this is not relapse refractory. These are patients having a haploidentical transplant upfront. So this was not considered standard of care, and this was all performed on a clinical trial. So patients received this conditioning regimen. So the conditioning is just the type of chemotherapy that's required to prepare the bone marrow for transplant. And then the GVHD prophylaxis are the medications we give patients to avoid graft versus host disease developing. And patient demographics you can see here. So there's 32 patients total. The median age was 25, but there were some older patients included. A lot of them were very severe, so they had very low neutrophil counts. And these are often the patients where we will consider transplant quickly. The reason for this being we want to get the white cells up quickly to stop infection from occurring. 33% identified as a minority. The clonality of bone marrow transplant means that they might have had an abnormal cytogenetic result on a bone marrow or PNH or some other abnormality. And these are the donors, which I won't go into major detail, but there was siblings used, parents used. So the important thing about haploidentical transplant is it really opens up the amount of donors that are available for transplant because you're not relying on a matched sibling, and many patients may not have a matched unrelated donor, but most people will have a haploidentical donor. And these are the results. So you can see here the overall survival is really good. So 93% at 3 years. And engraftment, so engraftment means the amount of patients where the donor cells successfully were engrafted into the patient. And this is how long it took for the neutrophils, so these are the type of white cells to engraft. This is how long the red cells took to engraft, so that was 25 days, and then the platelets took 25 days. Initially on this protocol, there were 3 patients who had graft failure, which means that the grafts didn't get into the patients properly. And they actually increased the radiation used to clear the bone marrow before transplant, and this seemed to help with that problem. And graft versus host disease was actually very low in this abstract, so 7%, which is, it's usually around kind of 20 to 30%. So this was very low. So I think, the thing to take home from that is that haploidentical transplant is emerging as a therapy for aplastic anemia in the upfront setting, and is something that, could be considered in a newly diagnosed patient with aplastic anemia. So now looking at pediatrics. So in children, generally at the moment, we do favor bone marrow transplant when a donor is available for the reasons I've already discussed. So in children, children tend to do really well with transplant. They don't tend to get as many complications as adults. And we think that the risk of developing relapse long-term or clonal evolution to MDS long-term, we really want to try and offset that in children. So we do like to do transplant when we can. That being said, there are still pediatric patients who receive immunosuppressive therapy. And one of the big questions was whether L-trombopag is as beneficial in children as it is in adults, because this wasn't really specifically studied much. And this is actually an older study that was published from the NIH a couple of years ago, where we looked at our pediatric patients who'd received horse AGG, cyclosporin, L-trombopag. We found that they weren't really doing any better than the patients who had received only horse AGG and cyclosporin. So this was the most up-to-date data that we had going into ASH, that maybe the L-trombopag is not needed in pediatric patients. But that was only looking at 40 patients, so numbers were low. So really, we need a bit more data. So this is a study actually published from Novartis. So these are the company that makes L-trombopag, and they wanted to look a bit more at the use in pediatric patients and patients with aplastic anemia. So they designed this study. So this was a phase 2 study. Looking at L-trombopag, horse AGG, and cyclosporin in both patients who had relapsed or refractory disease, or also treatment naive, meaning they hadn't received any treatment before. And there were 2 cohorts. So one was the treatment naive, i.e. untreated patients, and one was relapsed and refractory. And patients were followed up at these time points, as you can see here. And these were the responses that were seen. So I've already kind of gone through how we define a complete and partial response. These are the specific cutoffs that were used in terms of blood counts, and also what we use on our NIH trials as well. And you can see that in the treatment naive, so on the right side, the 37 patients, that the response rates at week 26 and 52, so at about 6 months and 1 year, we're only about 45%, which is actually quite low, and lower than we saw in our L-trombopag trial. So the reasons for that are not really clear, and it wasn't really apparent to me in the discussion from when they presented this. And in contrast, in relapsed and refractory patients, again, very few here, so only 14 patients, they seem to do a bit better, which is a bit unusual. Typically, patients who haven't been treated before would do better. But again, only 50% by 1 year. So if you compare that to a 6-month response rate in an adult, we would typically expect to see about 80% of patients responding. So that's a big difference between adults and children from what we can see in the data so far. And this is the safety. So I guess one thing is that there weren't really a lot of bad side effects that were seen. The main ones that were seen were these liver issues that I alluded to before when I was discussing avatrombopag. So there were increases in some liver enzymes that are listed here. And in some cases, they did lead the physicians to discontinue the drug. But these are known side effects and manageable if patients are monitored. So I think the bottom line there is that in pediatric patients with aplastic anemia, we're still not really considering L-trombopag standard of care like we do in adults. because the response rates we've seen are not as good as what we've seen in adults, and that in pediatrics, really we're moving more towards using transplant in the upfront setting if that is available. So now moving on to something a little bit different. So these are preclinical studies. So these are looking more at the, I guess, pathophysiology of aplastic anemia to try and develop new treatments for aplastic anemia. And these are two studies that were presented looking at potential new drugs and using mouse models of aplastic anemia to see whether these might be good medications to try in a clinical trial. So before I go into these two abstracts, I just want to give a brief overview of the pathophysiology of aplastic anemia. So in very brief, we know that aplastic anemia is an immune disease. There are cytotoxic T lymphocytes. So lymphocytes are a type of white cell, and these become hyperactive in aplastic anemia, and they drive what we call inflammatory cytokines. So these are signaling molecules that can drive stem cells to die, and the cytotoxic T lymphocytes drive this kind of cell death process that results in this empty bone marrow that you see in aplastic anemia. So that's why we give immunosuppression to patients with aplastic anemia, to try and dampen down this hyperactive immune system and stop the stem cells from being killed. So the first one that I want to discuss is this abstract. So this is the interleukin-2 receptor subunit gamma blocker. So basically, this is a receptor that plays an important role in mediation of many types of T cells, B cells, and NK cells. These are all parts of the immune system. And in particular, T cells are the ones that are implicated in aplastic anemia. And the idea is that by blocking this receptor and the cytokine, which is a stimulator, is being blocked, that means that that'll dampen down the immune system and help with aplastic anemia. And in fact, they've actually used this in lots of diseases, not just aplastic anemia, that have hyperactive T cells. And this is the mouse data. So this is a mouse that has been given aplastic anemia, essentially. And you can see that in the mice that received the antibody, that they have a lot better cellularity, so more cells in their bone marrow than the mice who didn't receive it. And they also have less of the T cells. So these CD4 and CD8, these are T cells that are in the bone marrow. And you can see that these are wiped out. So these kind of brown and purple blotches here are the T cells in the bone marrow, and they're wiped out by the antibody. And that also the hemoglobin and the platelet counts were higher in the mice who received this antibody. So based on the mouse data, there's actually a clinical trial that's running at the moment, looking at this. So this clinical trial is listed here, and this is the drug, this is what they've called it. And it's for patients who have severe aplastic anemia, who are relapsed and refractory, and who do not have a good option for stem cell transplant. And there's two aspects to this study. One is to see what the optimal dose is, and the second is to see whether it works and is safe. So as far as I'm aware, this is currently enrolling, but I am not personally involved in this, so I don't have any further details on this trial. And the second abstract that was looking at the pathophysiology was looking at the efficacy of JAK1/2 inhibition. So this was actually produced by our group at NIH. And this is a drug that we're looking at for many types of immune marrow failure. And ruxolitinib is a drug that has been used in other hematology diseases. So it's actually used in graft versus host disease, which is that complication of bone marrow transplant I talked to you about. And it's also used in something called myelofibrosis, which is another blood disorder. And this is just a summary of what we found in our mouse study. So we found that the T cells were reduced, we found the cytokines were reduced, we found that the blood counts improved, the mice survived very well, and also the CFU, which is a lab assay where we look at the growth of cells in a colony, was improved. So again, we're hopeful that this may be a good therapy for patients with aplastic anemia. And on that basis, this is a clinical trial that is in production, and we hope to have open this summer sometime. So this is an oral therapy that we can administer twice a day, and we'll administer it up to 6 months to see if patients respond. And we'll include patients with severe aplastic anemia, moderate aplastic anemia, pure red cell aplasia, TLDL, or hypoplastic MDS. So now moving on to the second part of this talk, which is PNH. So PNH clinically is this combination of hemolysis, so red cells breaking down, and that results in patients who have low hemoglobin. They may need transfusions, and on a laboratory assay that manifests as having a low hemoglobin, a high LDH, and this is because as cells break down, it releases LDH, and high reticulocytes, which are the baby red cells that I mentioned. And these go up in production because when patients are anemic, your body tries to compensate and increase the amount of immature red cells. Patients with PNH are also at risk of clotting. A lot of this seems to be related to the breakdown products of the red cells when they break down, and also bone marrow failure. So you know that PNH is strongly associated with aplastic anemia, and we think that this relates to the PNH cells surviving better in the aplastic anemia environment. And just to give a very brief overview of how PNH works. So it's a complement, an issue with complement, which is a part of the immune system that enhances or complements the ability of antibodies and cells to clear bacteria and also damage cells, and also to attack a bacteria's cell membrane to kill it. And as I mentioned, it's a rare disorder. Patients get this hemolysis, they get risk of clotting, and they get bone marrow failure. And there's two main types of cell breakdown that are seen in PNH, and this is kind of important when you're looking at the therapies that are available. So one is called intravascular hemolysis, and one is called extravascular hemolysis. And you can see here the pathway of complement, which I'm not going to go through in great detail as it's extremely complicated, but essentially the intravascular hemolysis tends to occur towards the bottom of the pathway in what we call the terminal pathway, and the extravascular hemolysis occurs earlier on in what we call the proximal pathways. And most of the PNH therapies that are licensed are work on the terminal pathway and inhibit something called C5, which is at the terminal part of the pathway. And this works really well to control intravascular hemolysis, but extravascular hemolysis happens earlier up in the pathway. So the more recent developments have been around trying to target the complement pathway at a higher level so that we can control both the extravascular and intravascular. And if you can see here at the beginning of the alternate pathway, there's two factors here called factor B and factor D that are important in this pathway, and they're the two aspects we're going to be looking at shortly. So there's currently 3 FDA-approved therapies for PNH, and these are the ones here. So there's eculizumab, which is the oldest and first licensed therapy for PNH. It blocks C5, so this is at the terminal end of the complement pathway, and this works really only on the intravascular hemolysis. There's ravulizumab, which is really similar to eculizumab. It works on the same pathway. The main difference is the timing, so every 8 weeks instead of every 2 weeks. And then there's this pegcetacoplan, which is a newer medication, and this actually blocks higher up the pathway, so in the proximal or earlier part of the complement pathway, and it can block both intravascular and extravascular hemolysis. This is administered as a subcutaneous injection and must be given every 2 weeks. So that's what's on offer currently, but there's been a lot of development in PNH, and this is a very hot topic. One thing to mention is that for pretty much any PNH medication, because you're blocking this complement pathway, so as I mentioned, this complement pathway are the ones that kill the capsules of bacteria. So if you block that, you increase the risk of some particular bacterial infections. So there are vaccination requirements that are required with all of these medications to prevent infection. So this abstract, I'm going to go through in reasonable detail. This was a late-breaking abstract. So this was one of the top abstracts presented at ASH in any disease. So this was, very exciting, and it's unusual that a bone marrow failure disorder would make it into one of these top abstracts. So this was looking at something called iptacopan. So this is a proximal complement inhibitor of factor B. So remember I pointed out factor B, which was up at the top part of the cascade. And I think the really good things about this drug are it's oral. So this is a pill. All of the medications that are licensed at the moment are either IV infusion or subcutaneous injection. And this is the Apply PNH trial. So this was a randomized multicenter phase 3 trial that enrolled 97 patients. And these were looking at patients who were already on a therapy for PNH already and were not doing well on therapy. So the standard of care with a C5 inhibitor, so these are the eculizumab or ravulizumab. So as I mentioned, these are the ones that block the intravascular hemolysis, but not the extravascular hemolysis. So these are patients who had their intravascular hemolysis controlled, but unfortunately the extravascular hemolysis still meant that hemoglobin was low and many were still requiring transfusions. And you can see here, so their primary goal or endpoint, there were 2 of them. One was to increase the hemoglobin by 2 and make sure that patients were not needing transfusion. And one was to see how many patients actually had a normal hemoglobin on this medication. So in green, you can see the patients who received the iptacopan, so this is the new oral pill, compared to patients who just remained on the standard therapy with eculizumab or ravulizumab. So you can see that 82% had a hemoglobin increase compared to just 2% in the standard of care arm. And we looked at normalization of hemoglobin. We had 68% of patients compared to just 1.8% of patients. And I think this is a very important outcome. So this was transfusion avoidance. This is patients who did not need a transfusion while they're on the trial. And over 95% of patients with the new drug did not require a transfusion, whereas only 26% with standard of care did not require a transfusion. And also very importantly, these are the safety data. So as I mentioned earlier, the main concern we have with all of these medications are the risk of bacterial infection. They did not see any increase in bacterial infections in this group. There were no patients who discontinued the study treatment because of any safety issue. There's just one patient who became pregnant who stopped the drug. So I think overall, that's a very exciting drug. It works really well for both the intravascular and extravascular hemolysis. That's a phase 3 trial. So that will be going to the FDA to look for approval based on that data. And the other one for PNH I wanted to talk about. So this is a bit earlier on in development. So this is just a phase 2 trial, so still early, but also interesting. So this is factor D. So this is also in the proximal part of the complement cascade. And this drug, I guess a sister drug to this drug, was used in a prior trial as an add-on to the standard therapy, which is the eculizumab or the ravulizumab. But it didn't really work that well when it was used as a single agent therapy. And this was to do with the kind of pharmacology of the drug. So this is like a newer version of this drug to see if kind of revamping the drug helped. And it seems it has. And I'll show you the data here. So this was a phase 2 study. It included 3 groups of patients. So patients who'd never been treated for PNH, patients who had patients who were being treated but were still anemic, and also patients who were on the prior drug that didn't have a very good pharmacology. And it included all adult patients and patients who had a lower hemoglobin or had evidence of hemolysis with the high reticulocyte count and LDH. This was the dosing that was used. It was 120 milligrams, but could be increased to 180 milligrams. And these are the patients who were enrolled. So median age 44. You can see their mean hemoglobin there was around 8, so pretty low. LDH, so that's a marker of how much hemolysis they were having, was high. So a normal LDH about 200 or 300, so 1600 is pretty high. And then history of aplastic anemia, not very many, so most were pure PNH patients. And this is a graph of patients at baseline. So just to note that these results are only in the patients who were treatment naive. So as I said, the trial included 3 different groups, but the results they showed at ASH were only for the treatment naive group. So these are patients who were untreated. And the mean hemoglobin rose from 8 to 11.8. So that was a big increase of 3.9 grams per deciliter. And the LDH dropped significantly from 1600 down to 300. And 1.5, so the upper limit of normal really depends on the lab, but 328 is kind of around, maybe slightly above the normal range. So seeing the patients had a good increase in hemoglobin and also had a good reduction in their amount of hemolysis. And this is showing the reticulocyte count. So as I mentioned, the reticulocyte are the baby red cells. So they're increased when there's active hemolysis or cell breakdown happening because the body is trying to compensate. So you can see that that dropped from about 200 to about 120. So it's still a little bit higher than normal. So normal would be between 30 and 110, but it was definitely dropped significantly. And this is a fatigue score. So patients with PNH often have very bad fatigue as one of their symptoms. And this is a way that this is measured using a scoring system. And an increase means that their fatigue improved. So it improved from a level of 30 to 43 using this particular score. And this was the adverse events. So I guess the main things here were there weren't any really bad adverse events, no deaths, no serious infections, and no thrombosis. So as I mentioned earlier, thrombosis or clotting is not a side effect of the drug that we see in PNH, but it is an issue that occurs in patients who have PNH. And by controlling PNH, we hope to prevent clotting from happening. And then you can also see that the patients here had the dose escalated. So most patients were able to have the dose escalated up to the 180 milligrams. So this was I guess the summary here was, this is a phase 2, which means it's an early trial, but I think did have some promising results. They were able to reduce the LDH, which is a marker of hemolysis. And they were able to prevent the extravascular and intravascular hemolysis. Fatigue improved, and it was well tolerated. So I think this will need to be further studied in a phase 3 trial, like the iptacopan I showed you earlier, but some promising data here in this arena. And that's it. These were the main abstracts that I thought were relevant at ASH. And I think we're also going to be sending around, or we'll be developing a sheet of paper with the other abstracts to see if there's any other interesting ones that could be disseminated as well. And I'm very happy to take any questions.
Thank you so much, Dr. Groarke, for the wonderful presentation. Our first question is about the AVA trauma pad that you mentioned for aplastic anemia. Is that something that is currently available for all aplastic anemia patients, or is that something that's in clinical trials? and not available to everyone at this time if they're having difficulty staying on the L-trauma PAG?
Yeah, so at the moment, it's not licensed for aplastic anemia. So I think you'd have to get it on a trial. Its current licensing in the US at the moment is for ITP and also for some patients with liver disease who have low platelets, but I don't think you'd easily get it for aplastic anemia because it hasn't been FDA approved here yet. So we're waiting on the trial results.
Okay, thank you very much. And the earlier presentation you had regarding how long to stay on the L-trauma PAG for patients that have gone off of the L-trauma PAG, do you find that if they have to go back on it a second time, the question is regarding how long you would stay on that the second time if your counts were dropping? Is there any data or any thoughts about patients that have to go back on the L-trauma PAG?
Yeah, there's not amazing data, but it's something we do a lot. So in general, if you relapse, if your blood counts drop after horse AGG, cyclosporin, and L-trauma PAG, what we'll typically do is restart you on one of the two drugs. So that's either the cyclosporin or the L-trauma PAG. And really the one we choose depends on how well you might have tolerated one or the other, side effect profiles, etc. And once we restart that drug, there's not like a hard and fast rule as to when we take you off it. Generally, what I would do is keep you on it for a certain period of time, maybe 3 or 4 months minimum. Probably longer, and see what the optimal response is. And once things are not getting any better for a couple of months, then I'll start to think about tapering it. So when we give immunosuppressive therapy, we stop L-trauma PAG after 6 months, kind of cold turkey, as in we just stop the drug completely. We don't do any type of tapering. But usually if someone is relapsed and they're back on the drug again, I will taper, usually maybe by 25 milligrams every month or so, and try and wean off the drug slowly.
Okay, thank you. Our next question says, if you do the oral version for PNH, would you be able to stop Ultomiris?
Yes, so based on the data that was presented at ASH, yes. So these patients were randomized to either continue on their Ultomiris or switch to this other drug. So that was the data that I showed you. So you would be stopping one and starting another drug, which would be the oral one. So I think, yeah, I mean, I think this is a pretty exciting drug. So hopefully we'll see once it gets approved. I'm not sure what the timeline for that is, but I think the data will be at the FDA or are at the FDA, so they'll have to make that determination. But I think this is the first oral therapy we have for PNH, and it's something that can be taken as a single agent.
Thank you. One of the next question is regarding the haploid transplants for aplastic anemia. Is looking at for a match for transplant, is a haploid transplant with a family member better than using an unrelated transplant?
Yeah, so I guess there's not really a head-to-head study to say which is better, but traditionally we would say that a full match, be that a unrelated or related, would be better than a half match. So yes, typically our order of preference would be number one, fully 100% matched sibling would be our number one preference. And then after that would be an unrelated 100% match. And then after that would be the haplo.
And the next question is, which of these studies for aplastic anemia or PNH are you most excited about?
I think the iptacopan, so the PNH oral therapy that I presented.
Right. Well, thank you so much, Dr. Groarke, for sharing your time and your expertise with all of us today and presenting all of this wonderful data regarding what's happening in the field for aplastic anemia and PNH. If you'd like to watch this webinar again at a later time, it will be available on our website within 2 to 3 business days. If we were not able to get to your question today, please send it to us at any time in 3 ways. Send an email to help@aamds.org. You can give us a call at 800-747-2820 or submit your question to our Facebook page. On behalf of the Aplastic Anemia and MDS International Foundation, thank you for joining us today and making us your resource of choice for information on bone marrow failure diseases. Our medical advisory board and team are always here to support you and your family, as we've done for the past 40 years. This concludes our program. Thank you so much, Dr. Groarke. Have a great day.
Thank you. Bye-bye.